You can see these are the places that are currently admitted. Since this is a single center tertiary cancer institute, we do have cancer patients. Suppose if you are in a multi-specialty hospital, you do have patients and referrals coming from either your cardiology or your ICU care or your post-op surgical refractory pain management or your pediatric ward. So since this is cancer, we do have their performance status, trying to understand their delirium, pain, symptom burden, how their performance status, and depending on that, that is how we will be going ahead for our rounds today. Since these are mostly for your refractory pain management and also patients with end of life care needs, this is something that we are trying to go ahead and look with a multidisciplinary involvement in our day-to-day practice. I would want to give a walkthrough of the patients that are currently admitted in the ward. Maybe you can get some idea. Apart from that, it also depends on where you are currently posted. It could either be in the OPD posting, or the cases do vary depending on the OPD posting or ward posting, or if you are in the peripheral on-call referral posting, or you are in a home care posting or a hospice posting. So currently in the ward, let us contain ourselves to the ward. So there are around 12 patients in the ward, and we do have patients who are admitted here, not just for end of life care. So I'll just run regarding what the diagnosis is and how we are managing here on a day-to-day basis. So I have with me a case of female lung who is in their terminal breathlessness, and we are managing for her symptom alleviation and palliative her symptoms for breathlessness. So she has also been a patient who has been in a clinical visit and also a previous hospice admission. So now she presented with acute breathlessness, and mostly she looks like she's in the last phase. So she's been here for her the end of life care needs. So this is admitted for pain management. The patient is currently ongoing palliative chemotherapy, and it's an inclusive carcinoma with metastasis, and the patient is admitted for refractory pain management. So it is not that we do manage simple pains in the ward. It is pains that are not subsiding with generic doses, or the pains that are requiring higher dose of opioid escalations or switching between the opioids. That is when it is an admission criteria for us to admit. So this patient has a fungating wound, bad urine care, and also a severe pain which is not subsiding with oral medication. Say he's already on 20 mg of morphine every 4th hour. Despite this dose, his pain is not being controlled. He also has agitation at night. So he could also be delirium features. So that is why he's. But this patient has finished the treatment, and this patient has been given for a treatment that is only for the best support. So this patient is here because of dysphagia and severe oral thrush and pain management. So for his pain, we are putting and titrating him to methadone. And it is not just trying to alleviate the patient's symptoms, but also trying to train the patient's family members regarding how they're supposed to manage an acute pain, oral hygiene, and feeding issues. So it is like a multidisciplinary involvement with not just a palliative physician, but also the nurse team, and also the physiotherapist, the head and the rehabilitation person cervix, who has been treated previously in 2022 and is on revision. So she has now presented with a low side effect, that is revelation cystitis. She's been having gross hematuria. So we have sent her for urology reference or multidisciplinary management. So she was actually psychologically worried that despite the treatment, she's been having gross hematuria, which is very disheartening for patient and the patient's caregiver as well. So for such cases, it is not just managing her side symptoms, that is her gross hematuria, radiation induced side effect, but still she has been having a lot of psychological issues. So it is not just managing that particular symptom, but also trying to make sure that she understands the nature of it, and trying to explain her that it is not a recurrence of the disease, rather it is something that is one of the complications that is sometimes anticipated. So there is another patient who is a carcinoma larynx presented with tracheostomy, poor tracheostomy care, juvenile secretions, unmanaged pain, disturbed sleep. So in palliative, it is not just a single symptom, but rather multiple symptom clusters that we usually tend to see. So when we try to manage his symptom cluster, it was not just trying to control the infection, but also tracheostomy care, educating the caregiver regarding how they have to go ahead for a further home-based management, trying to tie them up with a local palliative service center. And then, it's like a continuum of care where we, not just treat it at one point of contact, but also try to make sure that the patient's
entire trajectory till the treatment point is treatment. So it is not just patients who are at end of life that we are tending to see, but also attending to patients who are ongoing treatment, patients who have completed treatment, and also patients who are under evaluation and refractory symptom. Managing the patient and also the family as a whole, along with their treatment-induced side effects such as post-surgical mastectomies, if you have pain or wound pains, fungating wounds, malignant wounds, tracheostomy cares, all of it, and stomach care, all of it is under the palliative team, and that is what we see. Suppose if you are in a hospice based, so in hospice you have non-onco as well as onco, and in hospice also you have pediatric hospice and adult hospice. And then in home care, also similarly, we have a pediatric and a home care. So in hospice and home care, we also have non-onco, like if it's pediatrics, cerebral meningitis, or patients with polymyalgia, or patients with dystrophies, and patients who congenital abnormalities who are not able to survive on without any cause. Cerebral palsy, children with cerebral palsy, at end of life. So all of these patients are admitted under the hospice care. And in the OP, you get to see patients who are coming for the regular refills for pain management, who are ongoing treatment, and also patients who have finished the treatment and are currently on remission. So it is also like a supportive care and survivorship care also we get to see in the cases. I hope this will give you a clarity of what kind of patients that we tend to see on a regular basis. And if you have any more specific queries, I think those can be answered in the further comment section.